We are very happy to share with you the second cohort of the DiabDocs program. This is a really great program that was really spearheaded by Linda D'Amelio at IU and also Peter Maas at Stanford. They really hoped to foster encouragement and support for early career clinical research in type 1 diabetes and doing, creating this MD-PhD support program. So without further ado, I'm going to introduce Dr. Timothy Foster, Dr. Svetlana Azova, and Dr. Meghan Pauley. And just a little bit about Dr. Foster. He's an assistant professor in the Department of Pediatrics, Division of Endocrinology at the University of Florida. He specializes in pediatric endocrinology, focusing on autoimmune disorders, delayed growth, and type 1 diabetes. And he received his medical degree from Florida Atlantic University and completed his pediatric residency and fellowship in pediatric endocrinology at UFlorida in Gainesville. He's an active researcher and he leads studies on diabetes prevention, particularly in development of mRNA vaccines, contributing significantly to the field through both clinical practice and research. And he's going to give us sort of a thumbnail sketch, I guess, an overview of his work to date. And then I'll introduce Dr. Svetlana Azova, and then she'll do the same. And then I will introduce Dr. Meghan Pauley. So we'll have three. So thanks so much. Yeah, take it away, Tim. Thanks for joining.
Of course, thank you. All right, so like you already said, I'm going to review my research trying to prevent type 1 diabetes with mRNA vaccines or immunotherapy. So moving forward, we have to review that the stages of type 1 diabetes occur in a somewhat predictable fashion, starting with Dr. Eisenbarth's model in 86 that I've updated a little bit over time. So we have stage 1 with multiple autoantibodies, euglycemia, stage 2 where you still have multiple autoantibodies showing that persistent autoimmune process. Now with dysglycemia, you can think of it as pre-diabetes kind of stage, and then stage 3 is the usual type 1 that we're all pretty familiar with a symptomatic diagnosis. And so, of course, it's important for me to emphasize this because I'm mostly focusing on catching people in these stage 1, stage 2 timeframes with, of course, that hope that we could help people have a prolonged honeymoon in stage 3. So it's not an unusual idea, right? It's been around for decades, since the 80s, trying to come up with a way to stop type 1 diabetes from progressing, with a lot in the red that has not panned out in people, with some heavy hitters that are successful in green, but we're not going to line people up for stem cell transplants. And finally, we do have now teplizumab for stage 2. And so while I had started this research before teplizumab was fully approved, we still have a ways to go until we have better, more accessible, safer therapies. So we know from teplizumab that, okay, we can kind of prevent type 1 diabetes, but the thing that I like to emphasize is, right, we did one treatment, and the people on the blue line that did get teplizumab still have a continued rate of diabetes over time, even if it is better than the placebo. So it's not completely stopping diabetes progression, right? We still have a big gap of research to do. So the other thing is that this is an anti-CD3 immunosuppressive therapy, right? And we have still this lag in really conferring permanent immunotolerance in people. And even though my research is focused with mice, we've done it a lot in mice, but still have this gap of immunotolerance induction in people, and not just immunotolerance, but lasting immunotolerance, right? And so that's really what I'm trying to focus my research on, in coming up with a new method to try to reset the immune system. So my focus really then is, can we prevent type 1 diabetes with RNA lipid particles? Because we, again, need better lasting therapies that have minimal risk. And so to start off, I really wanted to develop and advance a safe and of course, efficacious RNA immunotherapy for type 1 diabetes prevention, with our original hypothesis that a pro-insulin RNA lipid particle aggregate would prevent diabetes in mice, ideally by conferring immunotolerance, right? So we have multiple layers of lipid that we then can put RNA into. In this case, originally it was proinsulin, murine proinsulin RNA, put it into the non-obese diabetic mouse model with the hypothesis that we would decrease those autoreactive T cells, hopefully increase energy of the previous autoreactive T cells, increase Tregs, and then, of course, yay, preserve beta cells. And so, kind of fast forwarding through that process in therapy development, what we had to start with were anionic or cationic kind of nanoparticles. And now, this technology and kind of recipe I had from my mentors in cancer therapy, and for them, they use cationic nanoparticles, and you can see in this D quadrant here that have a positive charge, and most of the RNA is within the nanoparticle, and it traffics mostly to the lungs. In reality, this is a picture of the relative expression, but it goes everywhere, but a high uptake in the lungs. And this is in contrast to the anionic that have less nanoparticle, less lipid, and so the RNA is coating the outside, giving it a negative charge, and you have greater uptake relatively in the spleen. And so, long story short, in the cancer models and looking at it from that standpoint, you rev up the immune system with the cationic more inflammatory reactions that come with dosing a cationic nanoparticle, which is great for cancer because you tell the immune system, like, hey, time to go kill that cancer. And it's still, at the beginning of this, wasn't completely clear if that would be the case with diabetes or not. And in the cancer world, the anionic isn't as efficacious. So eventually, what I sought out to do is compare both of these, right? So we chose these female NOD mice at 8 weeks when they wouldn't have hyperglycemia, but they would still have insulitis and insulin autoantibodies, and you can kind of track when they would be getting hyperglycemia. And the dose schedule pretty much followed what they first did with cancer, with giving kind of these booster doses up front at 8 weeks, 3 within a week, and then weekly thereafter. And so when we compared the RNA groups with the untreated, I'll show you, we first noticed that we couldn't even give all 6 doses for the cationic, right? So even though in the cancer world, you have kids that really have a high risk condition, so you can go straight to high risk therapy sooner. Type 1 diabetes, we're not going to have our kids and patients really put themselves at a high risk because we still have insulin, right? It's not the goal, but my first priority was making sure something would be safe. So with this cationic immunotherapy, the inflammatory response was so robust by the 3rd dose that they looked like this, pretty much all of them, where they looked very lethargic, and even in some of the mice, they continued to decompensate, almost this anaphylactoid reaction. And so, as if that didn't put a hard enough stop, the anionic, on the other hand, was very well tolerated. All the mice looked completely fine, no side effects at all, and we could keep dosing. And thankfully, this was tied with better efficacy as well. And so, again, we used this proinsulin RNA, proinsulin 2 specifically, because mice have 2 insulin genes, and we dose them either with the anionic or cationic limited by the adverse reactions. And so what you can see is that the anionic had pretty much 2/3 of them that were diabetes free, compared to the usual expected about 15% of the untreated. And then really in this experiment, there was no difference with the diabetes rate of the cationic versus the untreated. Now, I went with the whole goal of specificity using proinsulin, but the story doesn't really end there, in that green fluorescent protein, a completely unrelated RNA, actually has some effect as well. And so when we look at if we're just giving DOTAP, which is just the nanoparticle, no RNA in it at all, even that has a little bit of an inflammatory effect, as you can tell from these chemokine profiles. And so our hypothesis changes a little bit in that if GFP or other non-specific RNAs are having some effect, maybe it's not just that we could induce immunotolerance, but have a change in immunotrafficking. So what we see here in CXCL9 and CXCL10 are chemokines. And so normally when we have the beta cell kind of undergoing inflammation, it's producing CXCL9 and 10, having these chemokine trails that traffic immune cells towards the beta cell. And so if we're doing this with an anionic RNA immunotherapy that goes to the spleen, we think that this chemokine profile is then changing the immune cell trafficking away from the pancreas and more towards the spleen. And so the question then, is there a partial mechanism of immune distraction, or is that even the sole mechanism? Now, I have a lot of future to come with that. So of course, we'll see if we can block these chemokines if it takes away the effect of the vaccines, try to look at antigen-specific changes within the immune cells of the spleen and pancreas as well, with different assays and imaging. And I still have all the pancreas tissue and splenocytes from these prior experiments to still really analyze to get some answers to these questions of why it has an effect. What's interesting that we're just finishing up now is I had originally kind of wanted to look at if we had multiple beta cell antigens, because we're talking about stage 1, stage 2, stage 3, having not just one autoantibody, but multiple. So what if we took that problem and addressed it with not just having the one antigen, but two? And so people, of course, GAD is a major autoantigen, not as much in mice, really a lot more minor, but because of that translation, I still stuck with GAD. And what turns out is, as we're collecting this data, the diabetes onset is a lot more delayed, all the way out by 7 more weeks. So we're still kind of investigating the full data set with that, and again, the different profiles, but it looks even more promising if you do have a combination approach. And then the other thing to know is that we stopped dosing right at 12 weeks. So maybe we need continued dosing to keep this tolerance going. A lot of questions to still answer, but some interesting initial information. And I really couldn't do any of this without both support from the K12 program, many foundations, including the Junkin Family Foundation, CMN grants, the Peds Endo Society, ISPAD, JDRF, Endocrine Fellows Foundation, and then really the close mentorship of Dr. Sayer and Wasserfall, who have helped me kind of meet in the middle with this collaboration in the neuro-oncology cancer therapy, applying it to type 1 diabetes, and all of the wonderful staff that have helped me kind of learn the science as we go along.
Thank you, Tim. That was really interesting. I have a question for you. I wondered how, in terms of translating this into, the clinic, what are your thoughts? I mean, obviously, mice is just this, mice are the starting point,
Right.
right? So if you want to think about, some kind of GAD target, right? So there's some evidence out there that, certain endotypes are more responsive to that kind of therapy. How might you model that in mice, or is that not even, you're just going to have to go next level? You can't really stay in the mice for too long. It's just sort of a starting point.
Right. Yeah. So the other things that we're looking at are other mouse models. I mean, it's still an NOD backbone, but using proinsulin to knock out mice as well that are more consistent with all getting diabetes. And then really what our group is, even though my focus is type 1 diabetes, Dr. Sayer, of course, has a wide scope of kind of oncology immunotherapy. And so what we're actually going to try to look at is using this in autoimmune disease in dogs, specifically an encephalomyelitis model. Really not even a model anymore, because it's in dogs that get it naturally, because their standard of care is heavy immunosuppressive therapy to see if in a similar autoimmune kind of setting, if it would at minimum distract from the disease, or hopefully using more antigen specific RNA reprogramming as well. And then there are, again, other kind of mouse models I can look at, or rats, but really establishing safety in then another mammal model or patient in the vet school's instance would be helpful. The good thing is, again, from the mice on the anionic side, it looks completely well tolerated. We still have to continue additional doses to see, but so far so good. And the other part is, we've looked at a lot in people, right, with different insulin or GAD therapies, whether it be in a DNA vaccine with just proinsulin and immunomodulatory cytokines, or nasal or intralymphatic GAD. And the thing that's always kind of bothered me is we're focusing on one autoantigen, but a lot of times by the time we're getting a patient in that population, they've already met that criteria of multiple. So you've had antigen spreading occur already, to the point that are we really going to be able to reverse the clock with just one?
That's
Now,
an
I don't know,
excellent.
maybe two or three won't even be good enough, right? Because there's a lot of minor autoantigens and combinations that we don't clinically look at. But I think we need something more powerful. And the good thing about these RNA, and again, that's why I say immunotherapy, is because they don't just have the possibility of, oh, okay, expose the immune system to the antigen. They can redirect the actual immune cells to hopefully get them to also focus on it with some inflammatory response, but not as much as I said in the cationic. I don't want people getting that much. And because it also might not just be detrimental from a side effect standpoint, but from that preliminary data, possibly from a immune standpoint too.
Yeah, in the pediatric population, tough sledding. And then I just think it's great that you're partnering with sort of the oncology world and started thinking about this and sort of like getting, in a remission paradigm, right? So that's exciting. Here's a question from Laura Green. Is there an opportunity to repeat doses to prolong further?
Yeah, for sure. So the plan is to actually extend it to at least 18 weeks of weekly doses.
Mhm.
I did look at dosing at 4 weeks, so starting earlier in the process. It actually doesn't change the outcomes on diabetes rate or diabetes onset so much from just the proinsulin, but I haven't expanded on the multiple autoantigens. But something that was new to me was dealing with IACUC kind of animal care regulation. And as much as you would like to just say, things look good, let's do another 6 doses, you have a lot of hoops to still jump through with getting approval to do that. So that's upcoming soon.
That's an interesting point, and also something I guess that all the next cohort of diabetes docs should be keeping in mind. So thanks again for sharing your work. It's very interesting, and
Thanks.
can't wait to see what your group does next. I think the next presenter is Dr. Svetlana Zodev. She wants to put her slides up, that'd be great. And she's an attending physician at the Division of Endocrinology at Boston Children's Hospital, and she serves as the Assistant Director of Quality Improvement. She's also an instructor of pediatrics at Harvard Medical School, and she completed her medical degree at NYU and pursued her fellowship at Boston Children's Hospital. Her clinical expertise includes childhood obesity, diabetes, and endocrine disorders, and she has contributed to publications focusing on pediatric endocrinology with a strong emphasis on improving patient outcomes through quality improvement initiatives. Thank you, Svetlana, and we're excited to hear more.
Awesome. Can you guys see my slides without the presenter view?
Yes,
I always struggle with that. Okay, so you didn't see the
No
notes. Perfect. Okay,
Nope,
thanks so much.
Yes, it's
Thank you
great.
so much. Thank you. Thank you for the introduction. My name is Svetlana. I'm a faculty at Boston Children's Hospital and a DiabDocs Year 2 scholar. Excited to be here. And my primary project for the K12 has been looking at factors contributing to underutilization of medical nutrition therapy in pediatric type 1 diabetes. So as a bit of background, we know that medical nutrition therapy is a pillar of pediatric type 1 diabetes care, with both ADA and ISPAD emphasizing the need for comprehensive nutrition education by an experienced registered dietitian at least annually. Some studies have also shown that optimal dietary adherence has been associated with improved glycemic control and other metabolic benefits. However, we had also seen that MNT has been underutilized. And under MNT, I'm including kind of both diet quality, diabetes management strategies surrounding nutrition, as well as adherence with the recommendation for annual RD follow-up. There might be associated potential racial and ethnic inequities, and MNT utilization may be impacted by suboptimal prior RD experiences. Ultimately, the concern is that MNT underutilization may lead to unsatisfactory diabetes control and other health risks in this population, such as the development of overweight and obesity. And if I do have some time at the end, I did want to present just some preliminary data from an offshoot project from this work surrounding this. To start off, what I'd actually wanted to show is kind of how I was motivated to get into this field. And this actually came from a fellowship project that I was involved in. And this fellowship project was led by my primary mentor, who's the PI, Dr. Belinda Lenners. And it's a randomized control trial looking at type 1 diabetes management using a very low carbohydrate versus standard diet. And this is kind of, the model of how we've sort of thought about this. So kind of recognizing that the diet of many individuals, these days, especially kind of if influenced by the Western diet, is there's excessive intake of processed carbohydrates and refined sugars. This may lead to a mismatch between carbohydrate absorption and insulin action in patients with type 1 diabetes, making measures to lower postprandial hyperglycemia challenging. This then will ultimately lead to these kind of alternating episodes of prolonged hyperglycemia and recurrent hypoglycemia. So under this hypothesis, Dr. Lenners had set out to design this RCT to assess the efficacy and safety of a very low carbohydrate, aka ketogenic, versus standard diet in young adults ages 18 to 40 with type 1 diabetes. And this is just the macronutrient composition of the two diets. And you can kind of see, the biggest difference being in the carbohydrate content. And the primary endpoint from this project was change in hemoglobin A1C from baseline. I had contributed some adjunct projects to this, which I won't talk about. But what I did want to show, we're still in the process of kind of analyzing all of the data. But I wanted to show data from one of the earlier participants that really kind of struck me and made me more motivated to go into this field. So this is a participant early on in the study who was on a very low carb diet, who had this baseline tracing prior to starting the diet. And this is this participant's tracing after 12 weeks of being on the diet. And you got, everybody can sort of see the drastic changes that we're seeing here in their CGM tracing. And I think this really, for me, underscored the importance that, despite and with all of the advances and all of the improvements that we have made in diabetes management over the years, the role of nutrition is still really important. One caveat to this was that this participant was strongly adherent and very motivated and dedicated to adhere to all study procedures. We had since noticed that this has been a challenge in some of the other participants. So I think this is another part to underscore. And again, this kind of made me think about, how do I take this back to the pediatric population? And also kind of focusing on the adherence part of it. Really, I just wanted to try to understand, why, dietary management and making dietary changes so difficult for people in general, but, specifically for patients with type 1 diabetes. So this led me to my K12 project, whose main objective is to assess for factors contributing to underutilization of medical nutrition therapy in the established patients with type 1 diabetes. So these are patients that would have had diabetes for at least a year. So I'm excluding new onset patients for now. To help me answer this question, I'm utilizing the socio-ecological framework. So really considering the multiple levels of influences in the patient's life, including individual factors, interpersonal factors, institutional factors, and larger societal factors. My hypothesis has been that we will find decreased appreciation, both on the part of the child and the caregiver, of the importance of MNT and type 1 diabetes care. And this will be associated with suboptimal glycemic and metabolic outcomes in the child. So to do this, I'm utilizing what is called a participatory mixed methods design. In this research, I'm combining both quantitative and qualitative methodologies, and really kind of focusing on involving the participants in the research process. So this includes formulating and developing research questions, data collection, analysis. This is just kind of a schematic of the different phases of the project. So I did start out with a bit of chart review, which I'll talk about on the next slide, some preliminary findings from that. And then this led me to the first qualitative phase of my study, which involved doing semi-structured interviews and piloting some surveys with both caregivers and children. And I'll show some insights from this as well. Taking this pilot data, I'm currently in the process of fielding broad-scale surveys with caregivers and children. This is done out of Boston Children's Hospital, so from our local population, but also surveys of medical providers. For this, I'm actually utilizing a service to be able to field the surveys nationally, so to get a more representative kind of assessment of experiences, challenges, barriers to utilizing MNT in this population. Ultimately, once I have some of the preliminary findings from the surveys, I do plan to hold focus groups with caregivers and children to really engage them in interpretation, critical appraisal, and feedback of the survey results, which will ultimately allow me to build sort of a connected model of factors contributing to MNT underutilization. And this will ultimately be used to help design future investigational and interventional studies to try to improve appreciation and uptake of MNT. All right, I'll just kind of briefly summarize some of the findings from the completed phases of my project. So as I mentioned, I started out with a chart review to get me some preliminary data. And this was basically just looking at trends in annual RD follow-up among patients with type 1 diabetes at my institution, and then also trying to identify patient characteristics associated with RD engagement. So this is a retrospective study that had a longitudinal component. So I was looking at a 5-year period. Some of the results was that, sort of as kind of suspected, the annual RD follow-up rate over a 5-year period, so this kind of taken an average, was only 20.8%. There were some differences across the years, both kind of when looking at the total population, but also when subset by race and ethnicity, with sort of the kind of post or pandemic / post-pandemic years kind of seeing more of a downtrend, especially among Hispanic patients. And then we also saw that there was higher likelihood of RD follow-up with younger age and shorter diabetes duration. The other interesting finding was that we did see that RD follow-up was associated with lower hemoglobin A1C within the subsequent year. I will say this was a marginal finding once we controlled for things like age, sex, diabetes duration, CGM use, and mode of insulin delivery. The difference was only 0.1%. Interestingly, when we subset this by race and ethnicity, there was the greatest reduction we're seeing among Hispanic patients. They had a reduction of about 0.3%. Again, still kind of trying to use this data and sort of hypothesize of what these findings may imply, but definitely some interesting findings to get us started. I did also just want to, so kind of taking some of this data, what we did next was conduct a number of semi-structured interviews with caregivers and patients to really try to understand, as I mentioned earlier, what their experiences have been with MNT, what their perceptions are about the role of MNT, and what barriers and challenges they have had with incorporating medical nutrition therapy into their care. So I did this. This was some interviews were with caregivers of all type 1 patients under age 18. For the patient interviews, we limited them to the adolescent population, so ages 12 to 17. These are just kind of, and we tried to sort of, recruit participants that had diversity of these characteristics, which some of this was a bit harder than we had anticipated. But we think that we got a semi-representative sample to try to kind of diversify some of these factors. I'm not going to go through all of this, and we're currently just kind of finishing up the analysis of all of this data. I will just say that there's just such a deep breadth of information that we're learning from these interviews, and it's very exciting, a bit overwhelming, but really just soaking it all up and kind of using this to move forward with future studies. I was going to maybe just focus on a couple of the themes that are arising with some of the quotes to kind of go along with that. So kind of one of the themes that we're noticing is sort of this impact of early diabetes management experiences or perceptions that patients have had on how they approach food and their relationship with their way of eating. So this was a 13-year-old female with type 1 diabetes for 3 years. And this is just kind of a snippet of what she said. So a lot of people were very strong on if you eat less, then your blood sugar will stay low. So like for the first year, I kind of starved myself because people told me that was going to help my blood sugars. And eating less, it does keep your blood sugar low, but it keeps it too low that it's not worth it anymore. And I will say this is actually, this was not the only participant that kind of evoked this theme. There's definitely been other similar instances where this came up. This was, I thought, this quote was representative of two themes that are arising. So one, and this is definitely a big one, so this emphasis on maintaining normalcy, not restricting food intake. And then, especially for the teenage population, kind of this balance between caregiver involvement and child autonomy. So this was a caregiver of a 17-year-old male with type 1 diabetes for 3 years. So she says, the diabetes diagnosis has changed the way he looks at food, but he's always just been very much about knowing some of the differences between type 1 and type 2. And knowing with type 2, everyone's like, oh, you've got to change your diet. You have to do this. You have to do that. And the learning with type 1, you don't necessarily have to do it. Now, should you? Yeah. Have I told him he should? 1,000,000 times. Does he? No, because he feels different. He feels like being deprived of something, and he just wants things to be as normal as possible. And again, this is definitely a very common theme that has been arising both with caregiver and child interviews as well. And then I'll just show this last one because I think this is very timely, especially knowing how the devices have changed the landscape of diabetes management. And they are so wonderful and have so many advantages and have really improved diabetes control and quality of life among patients. But kind of just thinking of some potential downsides that may have arisen. So I thought this was a good quote. So this is the impact of technology and approaches to way of eating. So this is a 16-year-old male with type 1 diabetes for 10 years. So pre-Omnipod 5, I probably would have eaten the Ben & Jerry's ice cream. I probably wouldn't have eaten the Ben & Jerry's ice cream because I wouldn't have corrected. And I would have just woke up with a super high blood sugar. The Omnipod 5 is covering me now because I know it's inevitable I'm going to go high, but I won't not be correcting because I'm asleep. It'll do it for me. The typical double negative teenage way of speaking, but basically just saying that the technology will kind of kick in and take care of the hyperglycemia that arises from this food. Okay, if I have just a minute, I'm just going to summarize this quickly. I'm not going to go into a lot of the specifics, but I thought that this was, and I think kind of coming off of the what I had just shown, the slide that I had just shown. So as I mentioned earlier on, we know that nutrition is important for diabetes care, but I think we just have to think about its role in other aspects of care. In this case, specifically, how it could affect patients' weight trajectories. So what I set out to do is to kind of using our data, so the data that I had already collected, to look at what the obesity trends have been at our institution, and also try to see if I can find factors that have been associated with obesity. And I did this over a 6-year period, so I was able to actually look at this more recently as of last year. And just to kind of highlight, I think I'll just highlight 2 things. So one is, as again suspected or sort of clinically observed, the rates of obesity at our institution have risen pretty significantly from 12.8% in 2018 to 18.2% most recently in 2023. The rates of overweight stayed more or less stable, but definitely there is an increased trend. And then I just wanted to highlight this too. So the higher likelihood when I looked at the factors associated with obesity, there was higher likelihood with public insurance and child opportunity index. So this is sort of an index of a children's kind of neighborhood opportunities. It encompasses things like education, health and environment, and social and economic factors. So just kind of looking what their kind of prospects are, based on the area that they live in. So, both of these, the insurance and the lower COI, are, kind of proxies for maybe lower SES, more limited means, which can impact potentially nutritional opportunities and lead to increased risk of obesity. As well as, and again, this is why I thought this was really cool to present here. So there was also a pretty strong association with the use of hybrid closed loop systems. And the thought there is that, again, we haven't, specifically looked at what the specific factors are, but, could it be that these patients might have loosened some of their eating habits, kind of like what I just showed with the previous slide, where they might be eating foods they wouldn't have eaten before because they know this therapy is going to kind of kick in and give them that extra insulin to improve their glycemia, but ultimately lead to excess weight gain. So again, still looking into this a little bit more. I'll kind of skip over this for the sake of time. This is just looking more at this data subset by mode of insulin delivery. And again, these are just my next steps to complete all the analyses of this interviews, complete the collection of the surveys and the focus groups, and then again, kind of put all this data together, definitely collecting a lot, and try to build a model of factors to then use that to develop interventional investigational studies. All right, I think that is it. I just want to thank everybody for helping me with this, mentorship team and my study team, as well as obviously the K12, without which I would not have been able to do this work. All right, thank you.
Thank you so much. It's very interesting work and, really important as well. I had a couple questions. It's kind of interesting, this low carb diet movement, this sort of group, the type 1 grit movement. They have a large Facebook following. They follow Dr. Richard Bernstein, who himself is a elderly type 1 diabetic with low carb eating. And there's already some data in that realm. I wonder, can you draw on that population and learn more? There's already, if you look at their Facebook group, they have 51,000 in that group. So you just wonder, is that an untapped population to kind of gain, data from?
Yeah, and I debated whether to include this data, but I already knew this was getting so so extensive. So Dr. Lenners, who is my primary mentor, who I mentioned, actually one of her earlier projects, which I think she published this in 2018 at this point, she actually did tap into that group. And she did a survey study of that population to kind of get their experiences with the low carb diet. That actually served as her kind of the preliminary data that she used to design her RCT. From objective findings that she published, she did find that among those participants or patients who are in this group, their average hemoglobin A1C was about 5.7. So they definitely had really great glycemic control, and it didn't seem like they had more significant risk of things like hypoglycemia or DKA. And just as an aside, again, I know I don't have time to talk about this, but she also collected some qualitative data, which now that I'm kind of in this realm, when I came on, she essentially shared it with me. And I'm currently in the process of analyzing that data as well. So that's really just, those participants speaking to us to share their experience. So there's a lot of interesting data there too.
Yeah, no, it seems like a very large cohort that you could really just learn so much from. So that's exciting. And I guess I would also say one thing. I know, the work Osama Hamdi, he's an MD PhD at HMS. He's been outspoken about the fact that some of the technology can be facilitating this weight increase in obesity in type 1 diabetics. But, I just want to ask you what your thoughts are on the role of the diabetes educator. That's the first point of contact that most type 1s meet when they're hospitalized for the beginning of their diabetes. And how would you, consider or hypothesize that these data could be used to modify or change their messaging to help people kind of get in the water towards better control?
100%. And I'm glad you brought that up because that's definitely something that I've been kind of, noticing and really looking into. And I know I didn't talk about this as one of the themes, but definitely, both from kind of patient caregiver perceptions of the education they receive, it does seem like, and again, these are perceptions, so it's hard to know what actually is being said. It does seem like there are definitely gaps in sort of the education or the messaging that patients and caregivers interpret from their diabetes team, whether it's educators, endocrinologists, in terms of diet, and also in terms of, how to kind of utilize technology with diet. And I think I've also noticed just clinically that I don't think, our teams always do due diligence in terms of, counseling patients on, you still have to remember the importance of pre-bolusing and really making sure you're covering all your carbohydrates. I think there's definitely this perception that with these technologies, they could sort of maybe lack some of those practices. And I think it is up to us in a lot of ways to just say, like, these technologies are great, they work great, they will help you, but you still have to do, those things to make sure that, you have optimal control and just optimize your health in other ways as well, such as from a weight perspective. So 100% agree. That's definitely a field that needs additional work.
Yeah, there's room for improvement for sure. It's
Definitely,
almost like
definitely.
they're operating off a antique model
Yeah,
in some respect. That's
yeah,
what we hear. That's what I've heard.
yeah,
Anyway,
yeah.
so and then here's a question from Lena Hertz-Sanchez. How many RD visits per year have these kids at Boston Children's? How many RD visits are reimbursed per year in those with public health insurance? Good question.
That actually is a good question. I don't know if I know the answer to that, but I will definitely look into that. I know that definitely, the reimbursement, and I think in some of the other studies that I've looked at when I was kind of researching this, it's been a barrier to some patients to follow up with an RD if they're not able to get this covered by insurance. But I don't actually know the answer to your specific
It's a great
question.
question. It's
It
probably
is a good
something
question.
people
Yeah,
should think about in terms of
yeah.
this care cohort.
Not,
Here's another question. For a group that's a high risk that is at high risk for disordered eating, how was that accounted for?
in the which study? Like in this study?
I'm not sure. Laura, do you want to unmute yourself and ask?
Hi, sure. I think
Hi.
just in general, is that something that in these studies is watched for, is measured, is, is support provided? I think one of the risks of doing some of these studies is sometimes to bring attention to that.
Yeah, no, that's a great question. Trying to think of kind of how I will admit, I don't know if that's something I have considered probably as much as I should. I do have, just in general, because knowing even on the survey, some of the questions, could be somewhat sensitive. I do have a social worker who is part of my study. So, and there is at least on the surveys, a way to indicate if they would like to be contacted by a social worker. So I did put a bit of a kind of a safety net there, but I will admit I probably could have done more and should have thought of maybe doing a little bit more to address that. So I appreciate you bringing that up.
Another sort of, I wouldn't say safety net, but someone out there
Yeah.
who's sort of championed that to sort of disordered eating and type 1 diabetes is Lauren Bongiorno and her Risely Health initiative, where she has focus groups and she has boot camps, and they really do kind of discuss that at length. I think she's done a pretty good job, great job. And then I think we discussed this, the rising incidence of obesity, and specifically what aspects of AID may contribute. So we did kind of go over that a little bit.
Yeah. Again, it's hard to know. So I think some of the, because we do want to look at this prospectively kind of as the next step, because it's hard to get that data retrospectively. Again, it could be the loosening of the dietary habits, as I mentioned with that quote earlier on. It could be, again, like not pre-bolusing appropriately and thinking that the pump is just going to fix everything. And by doing so, it probably gives them more insulin down the line than they actually need. And as a kind of a consequence of that, the other hypothesis has been that with that sort of ramping up of insulin, eventually they can also then develop hypoglycemia. And by then treating hypoglycemia with uncovered carbs, that then in itself also drives weight gain. So again, a couple hypotheses that we have, but not something we can kind of more strongly prove yet, but we want to kind of look at this more prospectively down the line.
Well, it's great that your group is doing this, and congratulations for your
Thank you.
Participating in the DiabDocs program. And just in the interest of time, we're going to hop on over. Thanks so much to Dr. Meghan Pauley.
Yes, does that look right to everyone?
Yes, it looks perfect. Just a little bit about Meghan. She joined the Pediatric Clinic at Barbara Davis Center in Colorado in August 2023 as a physician scientist with a focus on type 1 diabetes. And her research interests include screening for and early detection of T1D and associated complications, especially neurologic and cognitive complications of T1D. She's an investigator in the autoimmunity screening for kids ASK program and closely collaborates with the coronary artery calcification in type 1 diabetes, this cacti study at Barbara Davis Center, and the Search for Diabetes in Youth search study at the Life Course Epidemiology of Adiposity and Diabetes Lead Center, both at University of Colorado. And she's received the National Physician Scientist Diabetes Doc K12 Scholar Award and a Colorado Co-Pilot Grant Award to support her work. Thanks so much for joining us as the third DiabDocs Fellow today.
Yeah, thank you for having us and for giving us this opportunity to share our work. So today I'll be reviewing the work that I'm doing as part of the DiabDocs program, which surrounds biomarkers of neurodegeneration and cognitive performance in young adults with type 1 diabetes.
Great.
Okay. So we know that diabetes is associated with increased risk of neurodegenerative pathology that underlies cognitive impairment syndromes and dementias such as Alzheimer's disease. And diabetes-associated complications like retinopathy, for example, are shown to compound these risks. And that does make sense because some of those complications like retinopathy and peripheral neuropathy do have neurodegenerative pathophysiology components. And actually, in adults with type 2 diabetes, retinopathy is suggested to predict Alzheimer's disease. But generally overall, the natural history of neuropathology in type 1 diabetes specifically is still not fully understood. And we don't know how having type 1 diabetes during critical neurodevelopmental periods, like in youth, may impact risk of neurodegenerative disease or neuropathology later in life. So thankfully, neurodegenerative pathology can be identified decades before the symptoms are apparent, and that is evidenced by changes in different body fluid biomarkers. So this study's objectives were to characterize longitudinal change in plasma concentrations of preclinical biomarkers of neurodegeneration or neuropathology from youth to young adulthood in people with type 1 diabetes. And then also to test for relationships among the degree of biomarker change over time and cognitive function and retinopathy status. So we quantified these validated plasma-derived preclinical biomarkers of neurodegeneration. All of these biomarkers are commonly associated with Alzheimer's disease, but can also be seen across other etiologies of brain pathology, such as cognitive decline and other neurodegenerative disease, and some even with different neuroinflammatory disorders. So of these listed, the phosphorylated tau or p-tau181 has the strongest relationship with the entire spectrum of Alzheimer's neuropathology and brain amyloid status. And then total tau is associated with Alzheimer's as well, but is a little less specific because it's also seen to be elevated in other neurodegenerative diseases, especially tau-led diseases like tauopathies. And then amyloid beta 42 and 40 are really most commonly associated with Alzheimer's. Then the bottom two, glial fibrillary acidic protein, or GFAP, is a general marker of neurodegeneration and also neuroinflammation. And then neurofilament light chain, or NFL, is also a general marker of neurodegeneration and also neuroaxonal damage. So when we are interpreting a plasma concentration of these biomarkers, for tau and p-tau181, as well as GFAP and NFL, an increasing level in plasma is interpreted to reflect greater risk of neuropathology or neurodegenerative disease. And then the opposite is true for the amyloids. A decreasing level in plasma is interpreted to reflect greater risk. But because there are so many different assays at this point for measuring these specific biomarkers, there isn't yet a defined diagnostic threshold or a cutoff value. The field is really working towards finding some standardization to better utilize these biomarkers and potentially move towards clinical utility. But as of right now, the most useful interpretation in research of these biomarkers is comparing them to healthy cohorts, and then also assessing trend or trajectory over time. And that's how those interpretations above were determined, is comparing people with disease and without disease. And we learned that increasing values for taus and then decreasing values for amyloids, for example, suggest risk. So this study included 45 participants with type 1 diabetes, some with and some without retinopathy, from the Search for Diabetes in Youth Study Colorado site. So I do have to just a quick shout out, a huge thanks to the Search study and the lead center at the University of Colorado for partnering with me. I was able to use stored data and plasma from the baseline Search study visit and then also a follow-up visit. The baseline visit was within 2 years of type 1 diabetes diagnosis, so right at the beginning. And the mean age at that time for this group was about 11 years old. And then the follow-up visit was on average about 11 years later. And by that time, 18 of the 45 participants had developed retinopathy. And in this table, you can see the participant characteristics at the time of the follow-up visit, and then separated out by retinopathy status. So you can see overall, the mean age at the follow-up visit was around 21 years old. And the two groups were relatively similar overall as far as age, diabetes duration, sex distribution, race, and their hemoglobin A1C. And then for the retinopathy group, I do want to make a note that 17 of those 18 participants that had retinopathy had only mild retinopathy. And then the other one person had moderate severity retinopathy. So biomarkers were quantified from both the baseline and the follow-up visits. And we used the ultra-sensitive Simoa platform from Quanterix Labs. We also looked at cognitive testing scores, specifically the NIH Toolbox test is what was used in the Search study, and then retinopathy assessments from the time of that follow-up visit. So there is a longitudinal component and also a cross-sectional component to this study. And for analysis, data was excluded if the biomarker coefficient of variation was greater than 20%, or if there were any measures missing. And then for biomarker concentration change over time, I literally just quantified that using a simple difference score, but I'll refer to that as the delta of the biomarker moving forward, so biomarker delta. And then I ran comparisons with t-tests or Wilcoxon tests, depending on normality, and correlations with Spearman or Pearson's as appropriate. So finally, some results. So here you're about to see the change in each biomarker from the baseline visit on the left to the follow-up visit on the right in each graph. The graphs are slightly small in order to show them all, but here we have p-tau181 and then total tau, and then amyloid beta 42 and amyloid beta 40, and then NFL and GFAP. And I do want to highlight that all of the biomarkers demonstrated statistically significant change in that average of 11 years. And with one exception, the change was in the trajectories that are seen in neurodegenerative pathology for each of the biomarkers. So the amyloids both went down, and then p-tau, tau, and NFL went up. The one exception to that was GFAP down at the end, which actually went down over time. And then just a quick note that the biomarker levels did not differ across retinopathy status, and the degree of biomarker change over time was not different across retinopathy status. So we also found that of the cognitive function measures in the toolbox, some of them did correlate with the delta for some of the biomarkers, specifically tau and p-tau 181. So tau negatively correlated with the fluid cognitive score, which is sort of an overarching measure of cognitive function, and also with the dimensional card sorting score, which is a measure of cognitive flexibility, and also the picture sequence memory score, which is a measure of memory. And p-tau 181 also negatively correlated with that memory score. But the other biomarkers did not correlate with any of the cognitive measures. And I also want to note there was no difference in the cognitive measures across the retinopathy groups. So we didn't test for any correlations with the cognitive scores by retinopathy status, since there weren't differences. So in conclusion, youth and young adults with type 1 demonstrate changes in markers of neurodegenerative or neuropathology over time. For the majority of the biomarkers, including NFL, the amyloids, and the tau-based biomarkers, these changes were in the trajectory that is seen in neurodegenerative diseases, such as Alzheimer's disease. And we also saw that the biomarker deltas for p-tau 181 and tau correlated with poorer scores on cognitive measures, specifically measures of memory and executive function. Yet, unlike what we see in type 2 diabetes literature, we did not observe any differences across retinopathy group, but we have to remember that our group was largely comprised of just mild retinopathy. So all that I can really say at this time is that mild retinopathy did not associate with the changes seen in biomarker concentrations. And then, of course, excuse me, these studies are really just a small first step toward understanding the trajectory of development of neuropathology in type 1. We need additional studies to really assess the long-term implications of these results and if these biomarkers really do reflect a higher risk of neurodegenerative pathology later in life for people with type 1. So like I mentioned, this study had a relatively small sample size of only 45 participants, so I have continued collaborating with the search study, and we recently expanded to include some of the other search study sites across the country, and I've been able to therefore double my sample size, which is awesome. So we're about to begin running the assays on this second set of samples. And then we will conduct an exploratory examination of other potentially relevant covariates like insulin sensitivity, BMI, and others. And I also plan to compare this study's results to a group of age-similar healthy controls to hopefully be able to truly demonstrate that these biomarker concentrations are more abnormal in people with type 1 diabetes compared to people without diabetes. And then lastly, just briefly, I'm very excited to be building even further on this question. So I just want to briefly mention, I will be partnering with my co-investigator in the neurology department, Dr. Coughlin, doing work to isolate extracellular vesicles that originated from the brain, but then crossed into the plasma. So these EVs can be thought of sort of as like little packages of waste or materials that have been discarded by cells. So we are going to be investigating what markers are carried on the surface of those neuronal EVs, as well as what cargo they're carrying inside. And I'll be using the same plasma samples that I've been working with from the search study. So this will be a way, hopefully, to sort of validate the results from the plasma biomarkers and see if these amyloid and tau proteins are also present in the EVs from the brain. And yeah, I'd like to thank my study mentors, of course, Dr. Shapiro and Dr. Snell-Bergen, all the study collaborators, and especially the Search Colorado study team and the lead center at the University of Colorado. And of course, I have to thank the DiabDocs K12 program, because without this program, this work would not exist. Thanks.
Fantastic. Thank you, Megan. I just had a quick question for you. Do you guys, when you, what was the A1C of these individuals in the study annually and overall? Did you look at those as you compared the changes in the neurobiomarkers?
Yeah, so I have them at certain time points along the way. So I have them at baseline, but they're all very low at the beginning because it's right around the time of diagnosis. And then had them from this visit, the final follow-up visit. And then I also have one in between from like a third visit in between. And I have done some just exploratory correlations where I took sort of an average of that A1, those 3 A1Cs to see if it relates in any way to these biomarker concentrations. And I haven't
Mhm.
found any relationships yet.
Yeah, so they were pretty high at the follow-up. They're still pretty high at 8.8 and 9. So you just wonder if that's a, is it a factor? Is that a contributing factor? But it'll be really interesting to see if you're able to sort of dissect that out as you dive deeper into these new samples. And the EV samples will also be very interesting to see. We'll look forward to see what you pull out of that study. Here's another. Here's a question. Can any of the scholars comment on what aspects of the DiabDocs program, other than the funding, obviously, that they found helpful? And yeah, so if you all can unmute yourselves and maybe share what you thought was most useful. This was a question I was planning to ask with time.
I mean, I definitely can start off with saying just the connection with everybody. So I love Megan and Svetlana and our entire group. We have kind of our own separate messages that go on between each other with our research thoughts or diabetes care thoughts. And then aside from that, then we also get kind of this constant communication with Linda and other experts from around the country, right? That have, even though they're administering the grant and acting kind of to help regulate everyone, they're there to constantly give us feedback in a mentorship kind of fashion that I guess I didn't expect. I knew they would be kind of giving us lectures and guiding us along the way. But it's nice to have that communication with people that aren't down the hall, but
Yeah,
down
no,
our
it's really
closest
great. I wondered, it's sort of in that same vein. Do you guys have much communication with the DiabDocs cohort, first cohort?
Oh yeah, like we're all together.
Great. So
The third
yeah, they're
cohort we
building.
need to like integrate into our constant communication more now because they
That's
just
great. They're
started.
building an ecosystem then of all these young researchers, right? With, sort of this clinical research focus. And it's really a unique way of thinking about things. And I do put a lot of the onus on Linda D'Amelio for sort of really driving this program. Svetlana, what's your aspect that you most enjoy?
I was gonna
Find
say,
helpful.
yeah, I was gonna say just even beyond like having like the communication and the mentorship, just being able to have opportunities for collaborations, like nationally, right? Because we're at times like so siloed within like our own, local communities, but now having the opportunity, already had other faculty approach us to kind of offer that, which has been great. The DiabDocs also has like a visiting scholar program where they essentially like send us to other institutions to be able to meet faculty there and build those connections and collaboration. So I think it's hard to get that if you don't have those opportunities. So I think I really appreciated that aspect of it.
That's fantastic. There's one more question from Megan, and I'll have her answer that offline to Laura Green, just at the interest in time. And I thank you all for your great and interesting presentations. As Alexis, my colleague, has said, great work in a very short period of time too. So fantastic. And we hope to hear more from you in the coming years. And just really hats off to what you're doing. Thank you so much.